Greetings, everyone. On behalf of all authors, we would like to thank Gastrointestinal Endoscopy for the opportunity to discuss our latest study entitled Endoscopic Sleeve Gastroplasty plus liraglutide versus endoscopic sleeve gastroplasty alone for weight loss. My name is Mohamad Itani, and I'm a postdoctoral research fellow at the Johns Hopkins School of Medicine. The study was performed at 3 clinical centers in Brazil. Dr. Anna Hoff was the lead endoscopist on the study. She is a trained bariatric surgeon and endoscopist. She is also an assistant professor at ABC Medical School, located in Sao Paulo, Brazil. We are also joined by Dr. Dilhana Badurdeen, who is an assistant professor of medicine at the Johns Hopkins School of Medicine in Baltimore, Maryland. Dr. Badurdeen, can you start by telling us why the study was done?
Thank you, Mohamad. And I would like to thank GIE for this opportunity to talk more about our study. So this study was done because, unlike bariatric surgery, the endoscopic sleeve gastroplasty procedure has less hormonal alteration-induced added weight loss that accompanies the anatomical change. Thus, combination therapy with ESG and liraglutide actually manipulates a similar mechanism of action both at the central and peripheral levels. Additionally, what we have noticed and what we've seen in previous studies is that there is a deceleration in the speed of weight loss at around 4 to 6 months. And in lieu of this decline, we decided to offer liraglutide at 5 months post-ESG to enhance weight loss. However, at this time point, the ideal time to start pharmacotherapy is yet to be determined.
Very interesting. Thank you. Dr. Hoff, can you tell us what the study adds to the existing knowledge?
Of course. First of all, I have to thank the opportunity given by Gastrointestinal Endoscopy and to you to show our work to our peers. We all know that obesity is defined by 2 major symptoms: lack of satiety and excess hunger. If the size of our stomachs was the only responsible to this complex matter, obesity has been solved long time ago. It's not. Of course, surgery as well as minimally invasive techniques do help our patients because they have a major role on those hormones that acts in our hypothalamus, our area postrema, and our vagus nerve. That includes about GLP-1s, oxyntomodulin, adiponectin, leptin, PYY. But after a while, in some patients, their hormone changes aren't enough, or we have to find a way to provide them an extra dosage of those hormones. So combining medications to those minimally invasive techniques, or even to a bariatric surgery itself, does provide a better and longer weight loss, as well as weight loss maintenance. This is the first study of many others that are already on the oven, and huge labs as well as tiny ones are working on different molecules or analogs as we speak, and therefore this is just the beginning.
Excellent, excellent. Dr. Badurdeen, how was liraglutide selected alongside ESG?
So this is a great question because liraglutide was actually approved by the FDA in 2014 for weight loss in adults with a BMI more than 30 or a BMI more than 27 with at least one weight-related comorbid condition such as hypertension or dyslipidemia. But it was initially manufactured as a medication for the treatment of diabetes. Liraglutide is a GLP-1 agonist, and it amplifies glucose-stimulated insulin secretion. But additionally, it also delays gastric emptying and increases satiety by central effects on the hypothalamus. So the proposed mechanism of the endoscopic sleeve, even though it's mainly restriction, it also delays gastric emptying, causing increased satiation. Thus, by combining ESG with liraglutide, we attempted to utilize the mechanism of action of these individual therapies to augment weight loss. Additionally, we felt that liraglutide was a good choice due to the added metabolic benefits as seen with a decline in blood sugar and due to its excellent side effect profile. The side effects that we see with liraglutide are minimal: fatigue, hypoglycemia, nausea, abdominal pain, or dyspepsia occasionally. The most serious complications, such as pancreatitis and thyroid cancer, those serious are very rare side effects. So we felt that liraglutide was the optimal medication, both because of the metabolic benefit as well as its good side effect profile.
Thank you, Dr. Badurdeen. Dr. Hoff, a multidisciplinary team was used in the study. Can you tell us more about its importance?
Oh, we cannot forget the role about the multidisciplinary team. We have this great opportunity to perform a great ESG and trace a track, but we cannot say one size fits all. The patient is the major actor of this movie that is his life, actually. And the dietitian, the nurse, the personal trainer are essential, as well as the WhatsApp group that we assemble when he undergoes the procedure. So the whole team can be together the whole time for whatever he needs. Being close is the secret.
Thank you. Dr. Badurdeen, what are the barriers to the combination therapy of ESG and liraglutide?
So the biggest barrier that we see is the cost of both the endoscopic sleeve gastroplasty procedure as well as liraglutide, and the lack of insurance coverage. And this is often the biggest barrier that patients face, particularly in the United States. But also liraglutide is a daily injection. And there are many patients who are just very reluctant to self-administer the medication.
Mm-hmm.
There are some newer medications that are coming out that, such as semaglutide, that can be injected weekly. But even with these medications, we will probably see some patients who are reluctant to use the medication because of the need for injection. Additionally, what we've seen overall with medications is patient adherence. So unlike other chronic conditions such as hypertension and diabetes, where patients are, where it is acceptable for patients to continue medications long-term, unfortunately, when it comes to the treatment of obesity, patients don't see this as a long-term chronic condition, and they don't want to take medication long-term. So this is one of the biggest barriers that we face. And I think it's important to educate patients as well as empower them with knowledge as well as reassurance that it's okay to take these medications long term.
Absolutely. What can you tell us about the future of combination therapy? How does it look?
Oh, as we said before, this is just the beginning. Other meds are being developed and we are performing better procedures, and some new devices are on the way, like POSE2. Our team is putting together our best efforts on discovering whatever is the best to offer right now to our patients. That includes the use of semaglutide, like Dr. Dilhana said. Sometimes I have these pillow talks with my son, and we think the future of obesity might as well be on combining our minimally invasive techniques to tiny subcutaneous implants that can be formulated for each patient, perfectly fit for that particular person. I like to think outside the box, and so do you. And being outside the box gives us an infinite solutions to a problem. So thank you all for the opportunity of presenting our paper and showing our work to the world.
Thank you, Drs. Hoff and Badurdeen, for being with us today and sharing your precious insight. And on behalf of all authors, we would like to thank GIE for the opportunity to share our study and discuss our findings.